Good evening, everyone. Thanks for joining. I'll give a few announcements before we get started. Um, my name's Cindy Davis. I'm a nurse practitioner. I work in oncology. I'm going to serve as our maestro or master of ceremonies for our webinar tonight. I just want to give some shout outs, some sort of run of the show information, and then what to expect as we go through our webinar. So first and foremost, thank you for registering. Our purpose of our webinar tonight is to give you more information on colon cancer awareness and prevention, as well as overall digestive health. And we understand the significance of early detection, prevention, and compassionate care when it comes to GI health. And our goal is to equip you all with knowledge and resources that you need. We have a wonderful panel of experts that will give you invaluable information today, and we'll give you some resources via email following our webinar. So before we dive into the informative parts of today, I just want to take a moment to extend our gratitude to our partners who've made our event possible today. So first and foremost, Cayuga Health System at large, Cayuga Cancer Center, Cayuga Primary Care Ithaca Mall that's officially been opened for 48 hours-ish, and Cayuga Surgical Services. And a personal shout out to our panelists. I appreciate all of your time and efforts developing this webinar. We've been planning this for a few months, and your time and commitment has been greatly appreciated. And I think this is going to be a great event tonight. And I also promised to make some special shout outs to our behind the scenes magicians, Krista Casper and our Marcom team, as well as Betty Haverlock, our nurse extraordinaire. We wouldn't be able to do all of the things without both of you behind the scenes. We appreciate that. We're privileged to present this seminar under the support of the American College of Surgeons Commissions on Cancer, which we are the proud recipient of their Outstanding Achievement Award. And the accreditations we hold, along with our network of esteemed partners, are not just badges of honor, but they're our commitment to our patients that they can trust us with their health and well-being. Together, we are dedicated to making a difference in the field of health. And like I said, my name's Cindy Davis. I'm a nurse practitioner in oncology. I've been working in oncology now for 4 years. Prior to that, I was a nurse working mostly in primary care and pediatric primary care. And my experience with oncology at large, but mostly with all of the wonderful panelists, brings the importance of what we're going to talk about, right? So in terms of primary care focus, but also the oncology specialty. So before we dive into today's discussion, let's take care of a few housekeeping details. So for those of you that are joining our virtual platform, the Q&A button at the bottom of your screen is your direct line to our panel. So if you have any questions during the sessions, please just type them in, and I will do my best to keep focused to answer those throughout the evening. You can also use the raise a hand function at the bottom of the screen. And again, our magicians behind the scenes can unmute you so you can ask when we get to the end of our informative sessions. So we want this to be as interactive as possible. So please ask questions, make comments, and enjoy where we're going with this webinar. So up first, we have our wonderful Alexi Clinton. Alexi was born and raised here in Ithaca and earned a bachelor's degree in psychology from Cornell before pursuing a career in nutrition. She earned a bachelor's in nutritional sciences from University of Arizona in 2005 and has been working as a clinical dietitian for Cayuga Health System since 2011. And she lives in Ithaca with her husband and 3 very energetic young cats, one of which we met very briefly before we went live. So Alexi, take it away with our diet health, please.
Thank you, Cindy. And good evening, everyone. Just give me a moment. I'm going to share my slides. Okay. So tonight I'm going to be talking about the best ways to prevent colorectal cancer by choosing foods that support gut health. The human gut tends to be overlooked and neglected. Your gut houses about 70 to 80% of your immune cells, so it's incredibly important to take good care of it. And the type of food that you eat has a direct effect on gut health. Some foods can actually damage your gut, while others have a protective effect. Meat in particular can have an inflammatory effect on your gut, which can raise your risk for infection, chronic disease, and of course, colorectal cancer. The types of meat that seem to have the most damaging effect on your gut include red meats, such as beef and pork, and processed meats, such as bacon, sausage, hot dogs, salami, and deli meats. In addition, consuming alcohol can raise your risk for colorectal cancer. More than one drink a day for men, and one drink a day for women and 2 drinks a day for men can increase your risk. Fiber, on the other hand, can actually promote the health of your gut and reduce inflammation. Because fiber has a protective effect, those whose diets are higher in fiber tend to have the lowest risk for colorectal cancer, whereas those with diets lower in fiber are more at risk. So, what should you eat? One thing you can do to protect your gut is to focus on lean proteins, such as eggs, fish, poultry, and as well as plant-based proteins, such as beans, nuts, and tofu, to help create a healthy environment for your gut. The other thing you can do is to make sure you get enough fiber in your diet in the form of whole grains and vegetables. Adults should aim for 25 grams or more of fiber per day. To make sure you're getting enough fiber, you want to focus your diet on fruits and vegetables. You should aim for 1.5 to 2 cups per day of fruits and 2 to 3 cups a day of vegetables. You can also find fiber in whole wheat pasta, bread, and high fiber cereals, such as bran flakes and oatmeal, as well as whole grains, such as brown rice, bulgur, millet, barley, and quinoa. Legumes and dried beans, such as kidney beans, black beans, and garbanzo beans, as well as pulses and peas and lentils, are also excellent sources of fiber. And a lot of these you can buy in the bulk food section at your local grocery store. To find out how much fiber a food provides, you want to look at the ingredient list and the nutrition fact label. And there's a handout that accompanies this presentation that you'll be getting in the email afterwards that illustrates the food label. So if you're buying, say, bread or pasta, for example, you want whole wheat or 100% whole wheat to be the first ingredient on the ingredient list. And then look at the fiber content on the nutrition fact label. Foods with 4 grams of fiber or more are considered high fiber foods. And keep in mind that if you're not used to getting a lot of fiber in your diet, start slowly, introduce a new food every week, and monitor for any effects on your digestion, including bloating, gassiness, or diarrhea. And then just some meal ideas. For breakfast, good choices are whole grain cereals that have that 4 grams or more of fiber per serving. Other choices include oatmeal or other hot cereals with some fresh berries or fruit. Whole wheat toast or English muffins or homemade bran muffin can also give you some extra fiber. And then for lunch, grain bowls and salads are a great way to get some fiber into your diet. You can cook up some brown rice or another whole grain, add some vegetables, some dried fruit, nuts, seeds for a fiber-rich lunch. And then you can always swap out white bread for wheat bread when you're making a sandwich. And at dinner time, you can try incorporating beans into soups, stews, and casseroles. Try serving a whole grain as a side dish. Brown rice, again, is an inexpensive and easy to prepare whole grain. And always try to make sure you have a vegetable as one of your sides. In addition, it's also important to make sure you're staying hydrated. You want to aim for at least 4 glasses of water every day. A good rule of thumb for how much fluid you should get per day is 1 ounce of fluid per kilo of body weight. So to get that number, take your weight in pounds, divide by 2.2, And that number is how many ounces of fluid you should consume per day. Water is always a good choice. Try to stay away from sugary beverages like soda, sweetened tea drinks, and energy drinks. And finally, I want to talk about accessing healthy, nutritious foods, as I know this can be challenging for some. Within the Tompkins County area, the Ithaca Free Clinic offers the Food Pharmacy, which is a collection of perishable and non-perishable food items, including fruits and vegetables, which depends on availability from local donations. They often have open hours, and you can always call ahead to the clinic to find out a good time to visit. Another great resource is the Healthy Food for All, which is a program that provides subsidized CSAs to single families and individuals in the county. CSA stands for Community Supported Agriculture, which provides a collection of fruits and vegetables from local farms. And finally, the Friendship Donation Network. They collect food from local farms and grocery stores that might otherwise go to waste, and distributes it to organizations around the county to distribute at no cost to those in need. They have an extensive list on their website of participating organizations. And then for online resources, I often go to the American Center or the American Institute for Cancer Research and the American Cancer Society websites for recipe ideas. And the cancer dietitian, Julie Lanford, has a specialized certificate in oncology nutrition in addition to being a dietitian. And I often use her website for ideas on various types of cancer recipe ideas and so on. So I hope you found this useful, and I welcome any questions you may have. Thank you.
Thanks, Alexi. That was fantastic. I loved the meal ideas because I think it's easy to say you should eat all of these things, but then maybe not knowing how to put a meal together. So a question came across, will these resources be in the after conference email? And yes, I will make sure that those are included because I think those are great resources and super helpful. So thank you again, Alexi, that was great. Next up, we have Dr. Pradhan, who provides care at our newest clinic at the Ithaca Mall, yes, primary care. So Dr. Pradhan is from Kathmandu, Nepal, where she also practices as a primary care provider. She's dedicated to health equity and has rich experience in primary health care. And I think the most important part, in my personal opinion, Dr. Pradhan, is your skilled pickle making, which I haven't gotten to experience yet, but maybe in the future. Also super enthusiastic about movies and food at large. So take it away, Dr. Pradhan, talking about other ways to screen for colon cancer.
Hi, thank you so much, Cindy, for the wonderful introduction. Let me first share my screen. It's a Can you guys see my screen? Okay, so I am basically going to be talking about colon cancer screening. This is just a brief introduction of when and how you should be talking to your doctor about colon cancer.
Dr. Pradhan, we can't see your PowerPoint.
Gotcha. So,
I can see your screen and you look fantastic. I just can't see your PowerPoint.
just a second. Let me just share. Is that visible? Is it visible now?
Yep, there you go.
Gotcha. Okay. Sorry for that. Okay. Can you see my screen now?
Yep, we can see your PowerPoint.
Gotcha. Okay. So I'm basically going to be talking about colon cancer screening, how you would be wanting to talking to your doctor about those screenings, and what are the things that you need to think about. The first thing is who should get screened. Screening at times relates mostly to your age. So I've made three three categories where, according to the age, everybody should be considered screening. So anybody who's above 45 years, up to 75 years, should consider getting screened for colon cancer. Anybody who's 76 to 85 years, regardless of how old you are, you should definitely talk to your primary care provider or a physician about the screening modalities. What are their pros? What are the cons at the age that you have it? If you're 86 or above, I think at that point in time, screening is not something that is indicated. Okay. I think this is a big question when we talk about colon cancer screening. What does actually screening mean? Screening means to do any testing that is done before you have any signs and symptoms of the disease. At times, I do hear this question with patients, hey, I do not think I'm at the risk of it. I don't have any family history. If it's going to come back negative, should I even be screened? Just wanted to let everybody in the audience know that screening necessarily doesn't mean that you have to have symptoms. Screening needs to be done regardless whether you, and it's basically done before you have any symptoms. This is done to catch the disease before it shows up. That's the purpose of screening. When we talk about diagnosis, which is what we do as physicians, that is once you have these signs and symptoms which show or kind of negate towards certain diseases, that's when we make the diagnosis of the disease. That's the big difference. I really wanted to point out this, that we're talking about screening. And if you're 46 or above, screening is very ideal for every patient or every person that is out there. Why am I talking about these symptoms or symptoms of cancer or possible cancer, not necessarily stating that these would, is my screen available or not? I'm sorry, I think there was a bit of a glitch. Okay. So not stating that the cancer screening, from what I've stated in the past one, below 45 to, sorry, I think there was a bit of a glitch again.
It's okay. We can see your screen, just not the slide deck, which I understand you're trying to pull back up. No worries. Technology is great when it works.
Yeah, I'm really sorry for the delay. Is my screen visible? Yep. Yeah. Sorry for the glitch, guys. Sorry for the glitch. Okay. I know we were talking about who should get screened, and I was talking about symptoms of when we should think about earlier screening. These symptoms, if they are seen in individuals less than 45 years of age, that is when you would consider earlier screening. Symptoms like if you notice you have blood in your stool, blood in the stool meaning frank red blood, or you notice anything like black tarry stools, those should be something concerning. Whether you're a female or a male, when you have noted low hemoglobin levels, a basic blood work called CPC, which is done routinely in your annual physical, is an indication. And if that happens, you should be thinking about possible screening earlier than 46 years of age. What are the bowel habits that you can notice when you're thinking about, hey, should I be a person who should get screened earlier or later? Is like if you notice any change in your bowel habits, meaning whether you used to have normal bowel movements and now you feel that you're more constipated. You've noticed that the caliber of your stools have gotten more smaller. You've noticed either diarrhea or even constipation frequenting in and about, because that could be symptoms that there could be some issues with your colon or with your gut in general. If you're trying to lose weight like I am, then that's a completely different thing. But if you have unintentional weight loss that you were not expecting in the past month or so, even a loss of 5 to 10 pounds, it's something that should be concerning if you haven't been expecting it. And all of these pointers should make you think about talking about your gut health and talking about a possible screening for colon cancer before you're 40, even if you're like in your 30s or in your 20s. That's the main point of discussing these symptoms. What are the type of screening? We've been talking about colon cancer screening consistently. What are the ways that we can do these screenings? The 3 screenings that can be done. The first, I'm pretty sure everybody's heard about it, is the colonoscopy. This is not a very pleasant experience is what I've heard, but this is a this is the gold standard. I'm pretty sure Dr. Katz is going to talk about it in detail. So I'm not going to touch much about it. The other 2 testings that can be done are CT colonography and stool tests. Stool tests in our facility, we do mostly fit testing and FOBTs. In other providers or in other services, there can be something called a guaiac-based testing as well. All of these testings are stool-based testing. So if you're talking to your provider about stool-based testing, please make sure you understand the type of testing that is done, because according to the type of testing, you would need to repeat these testings. If it is a guaiac-based testing, it needs to be repeated every year if it is negative. Along with it, you have to understand that you need to have some dietary restrictions with the guaiac-based testing. Whereas the FIT testing and the FOBT, which is done in Cayuga Medical Center and the facilities, usually we do not need any diet-based curtail or restrictions. And if it is negative, you would need to repeat it again every 3 years. Stating that, the other test that can be done is called the CT colonography. It's a machine where you would go in and imaging is done. What is the significance of this is good in detecting larger, or let's just say if there are any abnormalities which are more than 10 mm in size, CT colonography can kind of pick it up in the imaging. If it is 6 to 9 millimeter, it does, and at times it doesn't pick it up. Whereas if it is less than 6 mm, then CT colonography wouldn't be able to pick up certain lesions, certain polyps, certain masses, which is why, like I said, colonoscopy is the best test that we have at large to screen for colon cancer. The best part about the colonoscopy is it can be done like once. If it is a good study, then it's like done for the next 10 years. I do know that there are a lot of questions about, is there any modality, new modalities that are accepted for screening? There has been a recent new blood test where they look at a certain type of DNA called CEP9 DNA that is being considered for screening of colon cancer, stating that the gold standard for colon cancer screening still is colonoscopy. Any questions you guys have for me at this point in time? Because I think this is the largest chunk of talking about screening. Any questions in general?
Thank you, Dr. Pradhan. That was very, very comprehensive. There is a question that came through about the Cologuard testing, which I think a lot of people are going to have questions about just because it's on TV all the time. I'm not sure if you want to answer that now, but maybe we hold that to the end. That way we can get through the rest of our informative sessions, because there are a few other questions coming through as well.
Sure, we can definitely talk about that in a bit. I'm just going to talk about a few things to consider when you're talking to your doctor. There are different risk factors when we talk about colon cancer and screening of colon cancer. Anybody, and I'm repeating this over and over again, that anybody over 45 years of age is considered to be at average risk. I do hear it a lot from our patients that I'm at no risk of having colon cancer. There's nothing like a no risk. When we think about screening, everybody who's above 45 years of age, even without any major risk factors, is considered to be at average risk. Stating that when or what are the pointers that make you at increased risk when it comes to colon cancer is if you have had any family history that has colon cancer or polyps, let's just say that your father or your mother or your grandparents had noted some sort of polyps in their colon when they did a colonoscopy and something was removed. Those are the kind of informations that you would want to pick up, gather, get some information, and talk to your doctor about it. The one factor that we kind of miss out at times when patients think about colon cancer is also ulcerative colitis and Crohn's disease. These are inflammatory bowel disease and not IBS. I'm repeating that because there can be a bit of a confusion. So anybody who's got inflammatory bowel disease, either ulcerative colitis or Crohn's disease, are considered to be at increased risk. If you've had like family history of colon cancer and there were noted to be multiple polyps in the colon of your colonoscopy, and they had undergone an invasive surgery, noted to have different variety of cancers in the family, that's when you're thinking about higher risk. I mean, the Lynch syndrome and FAP sounds more of a medical terminology, but that is what it means. If you note, like, if your family members have ovarian cancer along with colon cancer or a multitude of cancers, then I think that's a very big pointer that you should sit and talk to your doctor whether you fall under increased risk or high risk. One other factor that I would want to add on here is if you've had any sort of childhood radiation or any sort of childhood tumor, as you're advancing towards adult care and talking to your primary care physicians, it's a good subject to bring up as well, because that also kind of does make you at an increased risk for colon cancer screening. So when we think about family history, a lot of the patients have this question: who is considered a first degree relative, who's considered a second degree relative, and who's considered a third degree relative. So anybody who is either your father, your mother is considered, and your kids are considered your first degree relatives. If one or more of your first degree relatives have had any sort of colorectal cancer, and it is very important to note the age when they had the cancer. Supposedly your father or your mother had that diagnosis at 60 or 50 years of age, then you would be considered to have the screening 10 years prior to this diagnosis. Let's suppose your mother had the diagnosis at, let's say, 45 years of age, then you would be considered to start your colon cancer screening at 35 years of age. That is what this slide means, age 40 or 10 years before the first diagnosis of your relatives. How often would you need to rescreen yourself? Would be every 5 years. If you've had one or more of your second degree relatives who've had colon cancer, second degree relatives, meaning your cousins, your grandparents, then that would entail you to have the screening at 45 years of age. Or if a relative's cancer has had the earliest onset, that's when you get screened. If it comes to that, you get rescreened every 10 years. That is considered to be at average risk screening, which is what we do. If you've had more than one of your first degree relatives who has had cancer, who has had noted polyps in their colonoscopy and really complicated history, then you would need to be screened at the same age as your relative's diagnosis, or at age 40. And you would need to be rescreened every 5 to 10 years according to the symptoms that you have, according to what the findings of your colonoscopy would be. I think these are the factors that you need to consider while you speak to your doctor, and the kind of information that you would need while you go in and speak to either your PCP or your physician about colon cancer screening. I think that kind of ends up my small presentation about the screening, and sorry again for the small glitches that happened in between.
No worries. Thank you again. That was fantastic. Lots of information, lots of great information. We do have some questions coming through that we'll answer at the end. I just want to keep this ball rolling because Dr. Katz, you're up and you're going to sort of be the star of the show talking about colonoscopies, which is everybody's favorite. So Dr. Katz grew up in rural Wisconsin before pursuing his undergraduate degree in biology and psychology at Swarthmore College. After graduation, he went on to teach high school biology in an underserved community in Texas through Teach for America before attending medical school at the University of Wisconsin. Dr. Katz pursued his general surgery training at the University of Utah, where he also completed a fellowship in global medicine at the Center for Global Surgery. His research focused on expanding surgical capacity in northern Ghana. He enjoys the tight-knit medical community here in Ithaca and exploring the natural beauty of the Finger Lakes region with his family, and we are thrilled to have you here.
Thank you, Cindy, and thanks everybody who is here. All right, thanks everybody. Can you see my screen? Perfect, okay. Well, I have the pleasure of talking about colonoscopies, which is everybody's favorite procedure to undergo. And hopefully I'll answer some questions about what it entails, why we do it, and really why it remains the gold standard. So first of all, some logistics. What is a colonoscopy? A colonoscopy is a thin, flexible camera inserted through the anus, following the curves of the colon and visualizing the entirety of the colon. On the screen, you can see a picture of the colon along with the various predictable turns. And the idea of the colonoscopy is to visualize the entirety of the colon. During this, we give most of the time sedation to keep patients comfortable and forgetful, so they don't remember a lot of the procedure. Some patients do this without sedation. What I tell people is just distending the colon with carbon dioxide, which we need to do to see the inside, is a little uncomfortable. It's a crampy abdominal pain. And then it's really those corners. Some patients have very straight colons. It's easy to navigate, minimal discomfort. Others have more hard to navigate colons. They're more tortuous or curvy. And that all kind of tells you how difficult the colonoscopy may be. Now, here are some pictures of what we see during the colonoscopy and a polyp. So in the middle of the screen, you can see that there is a little bunch of tissue, various views of it. We are able to insert some tools into the colonoscope and wires to cut out the polyp, suck it into a container, and send it to the pathologist. Polyps, we believe that most cancers come from polyps. The reason why is polyps, they're abnormally dividing cells, and as they're abnormally dividing, becoming more and more abnormal, there's a multiple hit theory where they undergo genetic mutations and eventually become cancer. Now, not all polyps become cancer. So during a colonoscopy, the goal is to remove polyps that may become cancer. It's hard to estimate how many polyps will become cancer. Estimates range between 5 and 10%. So the idea of a colonoscopy is removing polyps will reduce your risk for developing cancer, which none of the other screening modalities can claim this. So it is both a screening and also it is a preventative procedure. This is a busy slide that talks about the pros and cons of various screening modalities. So on the left side, it has the sensitivity. This is the accuracy of all of these modalities. And then each of these represents one that Christina, Dr. Pradhan, had mentioned. So first of all, colonoscopy, then you've got FIT, you've got CT scans, flexible sigmoidoscopy, which we're not going to talk too much about, fecal blood tests, and then FIT DNA, things like Cologuard. So you can see here that colonoscopy is the best study, the most sensitive for essentially all polyp sizes, especially the smaller polyps. I don't want to dwell too much on like the best study, but certainly when we look at these numbers, in general, colonoscopy is the most sensitive, the most specific, the most accurate. Other pros of colonoscopy, I touched upon this, but colonoscopies, by removing polyps, we are essentially removing polyps that can become cancer over time. This is from a very classic study, New England Journal of Medicine, that looked at various rates of colon cancer using multiple large databases. So here On the left-hand side, you've got the incidence or the occurrence of colon cancer. On the right side, you've got years of follow-up. And then each of these lines, so number expected from Mayo Clinic, St. Mark's data, SEER data, these are the number of colon cancers that were predicted according to these very large populational studies. Then they looked at the number of colon cancer cases in patients that were undergoing colonoscopies. You can see the number of colon cancer cases that they observed for patients undergoing colonoscopies were drastically reduced. Now, this is one study of many studies, and there's various estimates of how much a colonoscopy reduces your risk for colon cancer or dying of colon cancer. The numbers generally fall between 40 and 60%. Now, of course, the cons of colonoscopy. So unlike, the FIT tests, these other tests that we were describing, colonoscopy involves a bowel prep, which I'll touch upon in a minute. It can be uncomfortable. So just distending the colon is uncomfortable. Your colon senses that distension and it thinks, I need to have a bowel movement, and patients can have crampy abdominal pain. Most of the time that's mild. And I mentioned occasionally curvy colons can be more uncomfortable. Complications of the sedation. So we give medications to make patients sleepy and comfortable. Giving too much, it decreases the respiratory drive, and patients can have complications from the sedation itself. Bleeding is uncommon. It happens in about 15 of 10,000 patients. And then perforation, also uncommon. On average, it happens in about 3 in 10,000 patients. And then, of course, the big one is the bowel prep. So there are multiple types of bowel preps. There's multiple products on the market. In general, they fall into 2 categories. So one is polyethylene glycol. Polyethylene glycol is a large molecule. It's hyperosmolar, meaning it pulls water into the colon. It's generally given as a powder, and then you drink a bunch of water, 4 liters. It depends on the formulation, but you drink a lot of water and it essentially flushes things out. The other thing on the market, sodium phosphate, are essentially saline-based preps. So this would be things like Suprep, Sutab. These are newer. There's a lot of advantages. Some patients like them because they're convenient, they're smaller volume. Other patients don't like them because they taste salty. There's a pill form, which some people like. Some people prefer the liquid. Really, there are studies that look at which prep patients prefer. My experience is that nobody likes any prep, and it's hard to predict which prep is going to be the best for a certain patient. I just talk through the various pros and cons and let them decide. I will say sodium phosphate, the Suprep, the Sutabs, because it involves a lot of salt, there are some patient populations that we don't give that because of just higher risk for electrolyte imbalances. And before I get to my goodbye slide, it's all about the prep. So a poor prep, we cannot find polyps if there's a poor prep. And this is one thing that patients really, and we really don't like doing procedures that don't get the task done. So nobody likes the prep, but it really is necessary in order to get that reduced risk for colon cancer and for it to be an adequate and diagnostic procedure. So I thank you, and I look forward to any questions that are asked.
Thanks, Dr. Katz. I think probably the most common feedback you get, but we also get, is that the prep is the worst part of the colonoscopy. I think it's the forgetfulness part of the things that you provide that are helpful, but yeah, it's always the prep. So, okay, so guess what? It's my turn to share my screen, and a lot of this information is going to be let me go to my slideshow, is going to be repeats from what we've already talked about. So my PowerPoint is basically what are we talking about, right? So risk factors for colon cancer are what we talked about already: being overweight, lack of exercise, poor nutrition, smoking, alcohol use, age, family history. There's been some questions about how much exercise should we be doing, and general recommendations are 150 minutes of moderate intensity exercise per week. That doesn't mean training for a marathon, but it also doesn't mean walking around your living room twice a day. And as Alexia alluded to earlier, a well-balanced diet, eating the rainbow, and that doesn't mean Skittles, but eating colorful options on your plate with each meal. Certainly smoking cessation if that's feasible for you, and then limiting your alcohol. Some health disparities to talk about. We know that this includes health disparities for colon cancer diagnosis, but also what those disparities for screening might be. So overall rates of colon cancer are lower because of screenings, but in the population that's younger than the age of 50, that number is going up. So that's our screening recommendation. Age for screening recommendations has changed because of that. Certain racial or ethnic groups have higher rates of colon cancer. That includes American Indian, Alaskan Native, African American, Ashkenazi Jews. And then the health disparities as it relates to screening, generally from disparities associated with education level, income level, under or uninsured, and then those that have barriers to accessing treatment facilities. And that's sort of going to be a duplicate to this screen, which is what are the barriers to screening? And that's a lack of knowledge or understanding. And that may be a patient perspective, but may also be provider perspective, right? Not every provider knows all of the screening modalities or the recommendations at age of screening. Attitudes about screening and prep, like we talked about. Language barriers. If English is not your first language, you may not understand all of the terms that we're using. And to be honest, even if English is your first language, you may not understand some of those terms that we're using. Fear of the procedure itself, distrust in the healthcare system, transportation. One of the comments in the chat is having somebody drive you to and from your colonoscopy appointment. That can be a barrier for some folks. Taking time off of work to be able to have the procedure done. And then some provider recommendations. Maybe those recommendations aren't coming to all folks, to all patients all the time. We hope that this webinar has given you information to talk to your doctor about regular screenings, lifestyle modifications, avoiding tobacco and limiting alcohol use, advocating for your own healthcare success, but also staying informed and knowing what your recommendations for your health should be. And then this is obviously me. You can send any questions to me, which I believe are going to come to your email anyways in order to get information to me. So after our webinar concludes in a few minutes, you'll have a link to the webinar replay. You'll have some documents that you can review, a survey. In that email, you'll get information about how you can potentially get free FIT testing. If you don't have insurance, we have a program that will provide you FIT testing at no cost to you. So if you can't get any other colon cancer screening, some screening is better than none at all. And then obviously we'll review our use of the raise the hand function and our Q&A sessions. I'm going to stop sharing so we can get to some of these questions here. I think the first well, it's not the first question, but I think the question that came up, Dr. Katz, you answered the majority of the question, but are the stool tests a replacement for a colonography or a colonoscopy?
Yeah, they kind of are. So the stool tests are a screen that if you are undergoing those and they are normal, then it's a replacement for the colonoscopy. However, if they are positive or indeterminate, then the next step is a colonoscopy. And that is, I guess, an unavoidable recommendation. So a positive Cologuard should not be repeated with another Cologuard or positive fit and so forth. Once you have a positive result, then you are considered, you should be considered for colonoscopy, a diagnostic colonoscopy.
Awesome, thank you. And then Alexia, question about, two questions about diet. So water consumption, does that include tea and coffee? And then what about processed faux meats such as plant-based meats? I'm assuming the question is in relation to, are those protective or prohibitive?
Got it. Okay. Yes. So tea and coffee can be included in your total fluids for the day. You just don't want to go overboard on the caffeine. But yes, those can be included in your total fluid count. And then in terms of the processed plant-based foods, so I guess it depends, how different that food is from the food that it started from. Um, so like, something like tofu is, is lightly processed, but something that's, more processed that looks less and less like the soy that it came from, would be considered more on the ultra processed end of things. So those are to be avoided as well, even though they are plant-based. So more plants, more plant-looking plants.
Great, thank you. Dr. Katz, I guess this question is probably for you, or Dr. Pradhan, you could probably answer this as well, but are there certain patients where Cologuard is recommended over colonoscopy?
So I can take that. These are just modalities to screen. Like I said, we're talking about it. If anything comes back positive, we do need to get the colonoscopy done. It's just a matter of preference of what the patient would want. We always would want a patient to get screened with a colonoscopy, but if you want another screener or a baseline to know what you're having, then you can get a Cologuard. But I think the best test till date for screening colon cancer is still colonoscopy. That would be, I think, my answer. Anything you want to add on, Dr. Katz?
Yeah, I will say that Cologuard is for average risk individuals. And even you go to Cologuard's websites, they really outline that. So patients who have a family history of colon cancer, some of the other risk factors that Dr. Pradhan had mentioned, and then patients who have a history of polyps. So one risk factor for cancer is a personal history of polyps, certainly advanced polyps or cancer. And so for those populations, a Cologuard would not be appropriate nor really approved.
Great, thank you. A couple of questions have come through about sort of getting your colon back into normal function after a colonoscopy. Are there ways to promote that sort of gut health after a good bowel clean out other than, the tincture of thyme?
That's a good question, and I saw that too. Well, first of all, I would say I've heard this concern, and I think it exists. I usually tell patients, so all the things that Alexi had mentioned, so the good gut health things, high fiber diets, probiotics, and for patients with other gut issues to, IBS and other things to just try to get things back in sync. I've never come across literature about the bowel preps causing like gut issues. although for patients who have sensitive guts, I think in general, the polyethylene glycol based, the Miralax kind of based preps are considered to be gentler and cause less inflammation.
I think we'll answer one more question and I'll get the rest of these questions. And I can send a generic email to everybody that's registered with the answers, because I think probably multiple people have these questions. And Dr. Pradhan, I'm going to send this question your way. If someone has problems with eliminating stools and the consistencies of them, who would they go to for evaluation and possible treatment?
You come to us, you come to your primary care provider. You always come to us whenever you have these issues. The initial person to contact would be your primary care provider. If you're not established with one, I do understand that there's a scarcity, but our clinic is still accepting new patients, so you can always enroll in one, and then we'll, if needed and as needed, we will be referring you to possibly Dr. Katz or Cindy Davis here. But the first person to talk to about any type of gut health or any issues you're having would be your primary care provider.
Absolutely. In our link of resources that'll come through your email, I'll make sure that we add the Patient Access Center. So if you don't have a primary care provider, we can link you with our wonderful primary care providers in the community. That way, that's not a concern. I'm just going to take a few moments to give our closing remarks, but if you want to send any messages through or any questions through the Q&A function, we can do that. But we're going to close things up, and I just want to say thank you so much for everybody that registered. Thank you to our panelists. Thank you to everybody that made this event happen. I think we've taken such great significant steps at bringing about awareness of colon cancer, screening recommendations, and overall digestive health. And it's been really fantastic to learn from all of the panelists today. After the webinar, you'll receive an email, like I've been saying, which will also include a survey. So complete the survey if you'd like information about the fit testing that I talked about earlier, and you'll also have a chance to win a prize. You can support community health and help us improve future events. So we'll continue to hopefully do these webinars periodically. And again, thank you so much for joining us. And if you have any questions, please feel free to send me an email when that information comes through. And take good care of yourselves, stay healthy, stay well, and continue to be great advocates for your health.